Oh, you keep?
Oh, yeah.
Yeah, I think so.
Yes, keep you, Greg, yeah.
Good afternoon, everybody. My name is Sarah Burke, and I'm chairing the next session. And I need Yvette, Greg,
I'm not speaking.
Margaret, and Steve. You don't have a mic.
When I'm loud.
Okay, well, and George. Okay. So we're the only thing between you and your lunch, and Annalisa. So we'll get to you at we'll try and get to you at 5 to maybe. I mean, keep an eye on the time. Yeah, so that gives us 55, 57. Annalisa will come to you. So that gives us 20 minutes for discussion, and I am going to start with the two new faces who you haven't heard from, who's, well, you did hear from both of them actually. Margaret O'Riordan, who's a GP and former president of the Irish College of General Practitioners, and Greg Dempsey, who's Deputy Secretary General in the Department of Health. So Margaret, I'm going to go to you first. Just any thoughts or reflections on what you've heard this morning?
I must say I've been very impressed by the breadth of information that we were presented with today, and it has made me reflect on the complexity of what we're looking at. I mean, I'm coming at it from it, obviously came here today as a GP who was in my practice yesterday, and now I see the big world in front of me. So I suppose there were a couple of things that struck me. One, I was really interested in George's perspective on the government approach of interdepartmental working, because I fundamentally think that that's where we have to start. Too long, and I don't know what Greg will think about this, but too long the Department of Health is seen as the child who is constantly looking for more and going to deeper, and it's as if the Department of Health is on its own and not influenced by any other departments. And I was really interested when George referred to Saudi Arabia, the example there from the report there of them starting with that premise that we must look at welfare, social issues, we must look at education, we must connect everything. And otherwise, what are we at? So it might be a strange thing for me to have picked up as a GP, but that would be one thing. And then my other perspective would be very fundamentally looking at workforce issues, which is a really strong issue, and resilience. And from that perspective, I think we really need to focus on our junior doctors. I would be coming obviously from the bias of a doctor perspective. I'm very aware of all our other colleagues, but from a doctor's perspective, we don't look after our interns, our junior hospital doctors. We do not have the future. And I'm there's so many basic things that can be done to make their work environment much better and prevent them all going on the plane to Australia at the end of their intern year, which unfortunately happened with a full class from Cork University the year before last. So we really need to get fundamental on that. So I would be very focused on, without a workforce, without doctors, nurses, healthcare professionals, administrators, managers committed to the health service, we're not going anywhere.
Great. Thanks, Margaret. Greg, I'll give you next in.
And
maybe you might start on that, because it's certainly the key finding coming out of all of our research is the issue of workforce.
Yeah, sure. So I was just jotting down some notes because I knew you were coming to me.
Okay, well, go with your notes then. Go for it.
Well, I wrote down that workforce is probably our biggest challenge. We have got a lot of funding during COVID, but we've continued to get that level of funding. But we're probably going to struggle to actually spend it to recruit the individuals. So we did get funding that probably could have increased the workforce by another 10,000, but we made a decision that actually 6,000 was probably the max we could hire, both in terms of our process and in terms of people being available. So that is, and typically within the department, we consider our biggest challenge.
And just on that, Greg, there is sort of a dichotomy though between not being able to hire enough people and then letting go the people we train or we have in the system. And for me, that's equally important or nearly more important. And love to hear the strategies around that.
Around retention. Yeah, okay, well, I'll come back to that, but there was two other points I wanted to make. Governance is another challenge for ourselves. How we're making decisions, accountability. RHAs obviously is in terms of how from the top down and the bottom up decisions are made. So that's another challenge for ourselves. And then integration of care, the shift over to the community is another challenge. They're the three things that get mentioned and discussed a lot in the department. For me personally, however, underpinning them is our challenge with information. And since I joined health, and actually it's something that I've noticed and advocated a lot, we've got to get better at using, we're very data rich, but in terms of our analysis, our information, our understanding of what that's telling us, we're quite poor. And that means then that we're sometimes making decisions without really understanding. We're engaging with peer and other stakeholders without necessarily being in a position to really make our case. So for me, and I saw it today, and that's why I asked the question when it was mentioned there was caveats. For me, that should be one of the first things we're doing, is improving our understanding of the system, the interdependencies and so forth.
Steve, do you want to come in here?
Yeah, so many things buzzing around my head at the moment. So I think obviously that's one of the reasons why we want to do something like the Presta report, is to take stock, to take it almost not quite out of your hands, but it's always in your hands, but to take a step away from being very close to the decision making, to sort of do a cold hard look at what the data is saying, and then bring everyone along the journey and reflect on it together. And I think there's a lot of power in that. I'm hoping that when you're establishing your health system performance assessment framework, where you bring in lots of data, bring it into one place, and then what I'm hoping that will do is to provide a foundation for collective reflection, where yourselves, but also other partners too, and obviously we'd be very helpful. I'm very happy and keen to be helpful in that process, to collectively reflect, to collectively analyse the data, to see what can come out of that. And so I'm hoping that both from the HSBA, from the Presta report, we get that collective reflection going, whereby we can help with the analysis. We can't always help with the data. So there's a lot of stuff that we don't know about, but we can bring our expertise, and I'm sure our international colleagues would be the same. I know the European Observatory likes to play that role and facilitate policy dialogues on certain issues. So I mean, I think thank you for admitting that. That's truthful, but I think incredibly helpful. But then I think that's a great foundation for doing something together.
Yvette, do you want to come in? You've heard a bit more since you spoke earlier.
Yeah, no, I would like to come in actually on your point, because I totally agree that health and all policies is really important. Because when we think about the workforce, yes, that's the point I was making. We need train, recruit, retain. There are all kinds of ways, and we agree need to be done. But what are the other control knobs? I think, of course, you can perhaps solve things with different delivery models, different care models, I call them, where you try to do more with less, or see more people with less professionals. But we should not forget also the, prevent the need from arising, and especially, for example, mental health, which is a rising issue. The best policy, the best intervention to prevent mental health is a roof over your head, a good job, access to education, probably arguably more important even than all kinds of access to therapies. And we discussed actually that issue yesterday with the Social Protection Committee of the European Commission. And this was one of the outcomes that, if you don't want this incredible need overflooding our systems and leading to even more unmet need in mental health, and this you can apply to other parts, our care categories as well. I think we can do more there with this health and all policies idea. Good labor market policies, poverty reduction, that will also go a long way in mitigating these effects that probably date back to the financial crisis. So that,
Greg, do you have thoughts specific on that? My take on it would be we've been saying that's official policy for a long time, that we have health and all policies. Yeah. And actually we did it during COVID because, I say, the income supports, you know, and a whole pile of funds. But it's like now, post-COVID, I know we're not allowed to say that, we're reverting to type, and it's the department does the health system and healthcare or public health, but not really influence housing or education or transport.
Yeah, although we... within the department and the HSE, there is, under the Health and Wellbeing Division, a lot of work being done with other departments, education, sports and so forth, really to improve the health of individuals going through. Now, the level of funding is probably lower than in actual provision of health services. That's probably not just unique to Ireland. But we're certainly increasing that each year. So that will make a difference. And it is stimulating the conversations across the departments. Another thing I might point to, although we'll see how it works out, is the consolidation of specific disability services under DCE, DIY, and that's
okay. You've got to stop your acronyms now. Spell that out for us. That's your test of the day. Department of Children.
Well, Department of Children, I'll call it.
Okay.
There's a lot of words in it that I won't go into.
Are there any questions from the audience? Just, or will I keep it? Great. Here.
A question maybe for Greg, if you don't mind. You mentioned that...
Do you mind just saying who you are?
Sorry, Beatrice Cosgrove. I work with Philips. So we work across the HSE, or with the HSE. Workforce being one of your key topics and key issues going forward, which it is in, I think, health systems globally. And you mentioned that you got approval to hire 10,000, but thought that 6,000 was what you could do. To what extent are you then looking for technology, adapted intelligence, AI, call it whatever you prefer the title there? To what extent are you looking to use that to take pressure off the workforce, to automate work that's already being done, or to assist in that way? And is there some of the budget that's being spent on that can't be spent on workforce?
Yeah, I'll just clarify, we didn't get approval for 10,000, but funding. It's quite a complicated process, but someone could pick me up on that later on. We're certainly, so to explain what we're doing, we are doing a lot of work on strategic workforce planning to try and understand what our needs will be in the future, adjusted for the reforms taking place, so with more services being provided. And part of that will be considering the number of college places for the different elements. At the same time, some of the reforms, the use of ICT and so forth, considering productivity, and I mean that in the most positive way, to try and make up for gaps in workforce. Our new ICT strategy, or the refresh of the old strategy, will also consider that, but still fairly early days. But our approach will be to try and look at all elements of it and see how they each contribute to an overall solution and how they can support. There'll be synergies between the solutions. But probably, you probably haven't seen as much of the element you asked about yet. But I'm hoping as we come out of COVID and have more time now for the new world, you'll see more engagement on that.
I wonder if George or Yvette have any thoughts on that in terms of what's happening internationally?
Yes, I mean, the first thing to note is that it probably is as near a universal challenge as we've seen in the PHSSR country reports. But nonetheless, there is a fair amount of variation. I think there are certainly some health systems that consider themselves over-doctored, and relatively few, I think, that see themselves as over-nursed in terms of the balance of the workforce. As well as strategic planning and looking forward to, what's the pipeline, what should the numerous clauses be, how many doctors and nurses can we train, should we train, how can we make sure that they stay in the country as opposed to going overseas. There's also quite a lot of interesting findings in our reports around flexibility of the workforce, competency-based trainings, and other ways that you can, other means that you can introduce to essentially improve the efficiency and productivity.
And is there specific examples in relation to technology, to Beatrice?
In terms of technology, I mean, nothing that is absolutely at the top of my mind, but I think that it's absolutely manifest that in as much as remote monitoring and treatment is now possible at scale across health systems, it is certainly seen as the way ahead, and sustaining and promoting the adoption of telehealth in particular, I think is a strong feature of our reports.
Well, yeah, we talked about that issue also in the previous panel. Yes, forecasting is a big issue and planning. You see that everywhere. Not all countries are good at it or doing it systematically, and they should. And I put it actually on the slide. I don't think I mentioned it. And in terms of technology, of course, virtual wards are possible. We've seen, interesting pilots, and we need to explore those. What I said, all new care models, whether they involve technology or not, that will make it possible to do, less with more. We need to look at the full spectrum of control knobs that we have to, I think, relieve the pressure on the workforce. So.
Liz and this man here, does any other questions, let me know.
Sure, so Colin O'Donnell from Masters Omega, and I suppose reflecting on something about Paris in the last session about was academic discussion with a huge toll that's occurring in the health system. And maybe, George, we could get your view on how the PHS reports internationally have worked well and stimulate that concept of real change with the health systems. And we wonder for Greg as well, is there anything from the press reports to relate to something that Department of Paradise or delve deeper into for remedial action?
Thank you. Yeah, it's a great question, and we've really thought quite hard about how we can maximise our impact, and particularly how we can measure it, because you can never draw a one-to-one link between the publication of a report, having an event, and then a few years later policy change emerges. Did we have an impact? Did we not? But we can measure we can seek to understand the receptiveness of policymakers to the findings, and we have seen some very encouraging examples. So, for example, in Poland, and this goes back to the first phase of work, when we were still in the pilot phase, the Ministry of Health adopted a matrix approach to assessing new policy initiatives in terms of their impact on resilience and sustainability as they've been kind of conceptualized and analyzed in the Polish team's report. So that was a very good example. But as we're now in the second phase and coming towards the conclusion of the second phase, we've put much more effort into ensuring that policymakers are involved in the process of the research. And I think Ireland's a really good example of that, which means that the impact isn't limited to the output, as in the report is published, boom, big splash, and then let's see the recommendations adopted. But through policymakers being involved in the conversations, it's helping to essentially enrich the policy debate. And yes, we would very much like to sustain that engagement beyond the reports itself, and bring our expertise to that, work with the observatory and work with our partners at AstraZeneca and Philips, not just within countries, but also to share knowledge between countries. And again, I think the European Observatory is the kind of institution par excellence in Europe for that, so we'll certainly be looking to learn from them.
Thanks, George. I thought I was the source of feedback, and I'm not. Okay, Liz.
I suppose I have a broader question for anyone that you found was inspired by what you were saying about communication and about political messages, and Kathy, what you were saying about the public and science and politicians and stuff. I suppose really at first, I suppose to me, it's about how do we define risk, and then how do we communicate with members of the public in order to promote health, population health. I suppose at the start, obviously, we were very focused of the COVID pandemic. We were very focused on, infection prevention, control, and containing the virus, and and you know, preventing spread in ICU, protecting the ICUs, but then as you know, as part of the legacy, sorry, I'll wrap up. As part of the legacy, you know, we still see, you know, the risks where, you know, there's an increase in domestic violence, children, you know, have ongoing mental health issues. There's the children who depended, you know, on the food that they had at school. So there's lots of other risks and stuff. So I suppose as researchers and academics and scientists, how do you have those conversations so that we define risk, you know, and debate and disagreements, and then also then how can we come together then to make that political, you know, coherent message for the public?
Nice, simple question.
2 minutes, please.
Right, Margaret.
Okay, thanks. I mean, I suppose I would go down to the fundamentals, to the bottom of your question, which is how do you engage the public? And then I would say, how do I engage patients on a daily basis? And I suppose, to be blunt about it, you have to keep your message simple. I think the British government might have been challenged on a lot of its approaches to managing COVID, but they were very good at the keep it simple messages, which were effective. So all our attention spans are fairly limited, and the public is bombarded. We are all members of the public. We are bombarded every day by messages. But if it's a health message, it needs to be simple and something I can do now, not something for the future, something I can do as an individual. So it would all boil down to distilling all your research and all your findings into a really simple, what can I do as an individual?
Anyone else want to comment on that?
Yeah, I think you were alluding to this, what I also put on the slide, there is trade-off to be made, right? That's, I think, what you mean as well. What we saw in the early response that, you know, all the measures that were implemented were all very based on the very qualified assessments, also mostly of virologists, you know, really looking at it perhaps with a narrower perspective than maybe somebody like us here. Increasingly, we saw that those outbreak management teams, they were often called, were taking in different disciplines. And I think that's the message, that we need to be talking with, you know, researchers from various disciplines, and then, you know, to be aware that there are trade-offs to be made, you know. Are you going to accept maybe higher mortality from COVID, or, but at least have children in school, you know? So these are the hard discussions that you need to have and openly and transparently discuss.
Greg, any thoughts on that?
Well, I think one good outcome from COVID was previously the department in particular was very reactive in terms of its communications and dealing with typically criticism or scandals or whatever that were occurring. During COVID, we focused much more on developing a communication strategy that set the overall context and tried to position the department as a trusted advisor. And then local communications could take place in that framework, that environment. And we thought that was quite successful. And as we go forward now, our health and wellbeing division, again, which is probably the one that gives the more kind of health advice, staying healthy, wasn't quite branded as Department of Health, and we brought that into the overall communications. So it'll be the department doing, if you like, the strategy, the contextual comms, and then the department under health and wellbeing and the HSE, and then local providers under the RHA giving the specific messages. And we think that'll be more effective than the way it has been in the past.
And I think it's something that was done very effectively during COVID, particularly the never-ending press conferences where you left so the very last member of the media shut up, and the NEPIT or Attorney Dillon engaged, and I think that really helped public education and dialogue. And more recently, Lisa Smith's work around trying to get other people to take the debate again, very powerful messaging. Steve, I'm going to leave the last word to you, and then I'm going to hand over to Annalise.
Okay, very good, thank you. I was just thinking earlier, Colin said he didn't like permacrisis, so I've come up with a new term. It's called shock jam. Why not? Which may be more appropriate because permacrisis implies it's not going to end, where shock jam just means you've got different things coming at you from different directions. But I think there is something about, with the environmental issues, with the fragility of globalized banking, you know, with globalization and epidemics and pandemics, we are in a situation where we're more likely to come across more shock. So I think we have to engage with that reality, whether people like it or not. I think in terms of the catalyzing thing, I would rather see that we could try and do something positive out of the different shocks that we're facing. I'm worried that the cost of living crisis will pass us by because it is a slow shock and it doesn't impact the middle class. Well, it impacts the middle class much less than it does people who are kind of just on the breadline, and particularly some of our healthcare professionals who are not paid very highly at all. I would be very worried about them, you know, and their demoralisation. So I think the idea is to try and get something good from terrible circumstances, and they are indeed terrible, and they've had a huge toll. But I think having that, you know, slightly that constructive attitude through the research, I think is quite important. And I think throughout all of this research, we're trying to see how do we avoid these problems happening again, or how do we mitigate them. And I think that's an important thing.
Okay, great.
Thank
That's
you.
a good way. So thank you very much to our panel.
Well, thanks very much for inviting me to close this. It's been, I think, amazing as a member of the public, as a funder, just to listen and to have the concept. I think the learning of the concept of resilience, but also the sustainability, because of course you can be resilient, but then go down after if you don't have the sustainability. In terms of the workshop today and the discussion, I think is going back to Evot mention about you researchers have to, get out there really more and linking with knowledge user. And this is very much what this program is about. Research leadership is one of the foundation of our career, the framework, which is really to build capacity and capability in health and social care researchers. So it's about academic research, is about research that is in the interface between academic health service and clinical and social care, but it's very much about driving changes. So research leaders, how we are funding them, it's about really partner with the knowledge user to address relevant questions for the needs of the population. And we know how COVID has been dramatic, a crisis, whatever we want to call it. But I think from what I'm hearing very often in conversation, it's probably with the learning. I'm not saying it's probably an opportunity, but I think, even listening at the Sphere conference last week, and Brida Smith said, how COVID has probably emphasized even more the need to have a healthcare system, a public health or population health that is fit for purpose, that it's for today and not just for tomorrow. So we are talking about workforce. HRB is really focusing on the workforce of researchers that can drive evidence that can be translated then for the use of knowledge users. And really what we are here today, what is my last word before lunch, is as a funder, as a researcher, as knowledge user, government department, we are here really to improve our healthcare, the delivery of healthcare, our patient experience and patient care. And I think we are here, that's our common purpose. Let's try to do better. Thank you. Thanks very much.